You're listening to the NeuroCareers podcast with Dr. K. Episode number 10. Dear listeners, it's that time again. A time for us to dive into our exploration of careers in neuroscience and neurotechnologies. And our today's guest is Interventional Neuroradiologist, Dr. Kristine Blackham. Thank you very much, Kristine, for joining us. Welcome. Can you please introduce yourself and also tell us where are you working, in which part of the world? Our podcast is international and people are joining us from all over the world. Thank you.
Hi, Dr. K. I'm happy to be here. I am right now working in Switzerland. I have been there for 7 years, even though I went to medical school and did all of my training and the first years of my job in Cleveland, Ohio. That's where I met my husband, who's a German national. And after 10 years of having a long distance relationship, we both relocated to the University Hospital of Basel in Basel, Switzerland. We're both in the radiology department. I do neuroradiology and he does everything below the neck. He's also the vice chairman.
What brought you to neuroradiology, and not just neuroradiology, but interventional neuroradiology? And maybe you can tell a little bit our listeners that what is neuroradiology and what's the difference between just neuroradiology and interventional neuroradiology.
Yes. Well, radiology itself is a residency program after medical school. During radiology residency, you will learn about abdominal imaging, neuroimaging, pediatrics, musculoskeletal imaging, and so forth. It's really quite a large volume of material. Most people do fellowships afterwards. The reason I chose the neuroradiology fellowship is that it has this option of doing intervention. And I was very good at doing interventions in the body. And I felt that taking on the challenge of neurointervention would be something really stimulating for me. And the difference between neuroradiology by itself and neurointervention is that neuroradiology by itself is reading and interpreting CT scans, MRI scans of the brain and the spine. And the interventional component is that you do minimally invasive catheter treatments of diseases that affect the brain, like strokes, ruptured aneurysms, unruptured aneurysms, and so on. So it allows me to have some weeks where I am sitting calmly in the reading room and studying images, and other weeks where I am actively seeing patients and treating patients.
Did you always know that you want to be a medical doctor and that you want to work with the brain, or this developed through time?
I did always know that I wanted to be a doctor. My parents are both radiologic technologists. They met in X-ray school in 1963. And that was a big part of my life growing up. One of my first experiments at a science fair when I was maybe 10 years old was growing green beans from seeds that had been progressively radiated under the X-ray machine. Yes. So radiology was a natural choice for me during medical school. I mean, I really tried to be open. I think my second interest was medical oncology. That would have been my plan B. But I was able to get into a residency program in my hometown at University Hospital of Cleveland quite easily. So that really worked out.
You knew what you want almost from very beginning.
Mm-hmm.
You also mentioned that you knew that you are good at doing intervention in the body. This brought you to this choice of interventional neuroradiology. What skills do you think made you good at doing interventions? Some people would choose just reading images. So what particular skills make a person good at interventions?
That's an interesting question. That's a great question. I think it has to do with temperament somehow. You have to have the nerve to stick the needle into the artery and have that blood shooting back at you. And that's like the very first thing that you might do as a resident. And be able to put a floppy wire that's like flying all over the place, keeping control of it, put the wire through the needle, then you exchange the needle for a catheter and so on. And it just escalates from there. I mean, there's a lot of wires, a lot of catheters, and a lot to learn really quickly. It's almost a whole new language, but it's having the patience and the interest to see how can I get from point A to point B as quickly and safely as possible. And also standing there potentially for many hours. You have to have the tenacity and the strength to manage complications if they occur, and then stay after hours until the patient wakes up, until you know that the patient's okay, until you know that all bleeding has stopped. So it's an investment in time, it's a commitment, and it's a work culture that's different from the reading rooms, which are a lot of times away from the patients and you don't have much patient contact at all.
It's so interesting that you chose the work that is more stressful, actually, that requires making decisions and life-saving decisions. And probably it is more challenging rather than just reading images. So what called you from within actually to take on the challenge and not to choose just a stable, not very stressful type of work?
Well, I don't want to say that imaging is not stressful. It actually is, because ergonomically, now that I know this after being in the field for 20 years, it's quite difficult to sit at a computer and dictate with one hand and scroll through images with the other hand and maintain focus. Every image that you're looking at, and there's a person behind it, and the interpretation needs to be made correctly. That is a certain kind of stress. But you're right, life and death decisions in the acute phase, like with stroke or ruptured aneurysm, that's something you have to be actively willing to take on. And it's not something that you learn how to handle in medical school. It's something inside you where you know that you are up for the challenge. And the immense satisfaction of being able to help someone is probably the biggest motivator. With minimally invasive techniques, draining an abscess or coiling an aneurysm, and having the patient wake up and be so thankful that you were able to do this without them having to have a large operation is really what makes it worth it, yes.
What were the biggest challenges on your path for becoming an interventional neuroradiologist?
Well, I might use a coaching phrase at this point. I mean, you and I are both certified life coaches. Firstly, the difficulties of being a woman, a wife, and a mother during training. And I will come back to that. But actually, now that I have learned coaching concepts from our life coach school, I know that the biggest challenge that I always dealt with were my own thoughts. Because I actually can combine those two thoughts about being a woman and having to deal with my own thoughts like this. For example, if you've got a child and you have a husband who's not in medicine and you're showing up to work and you have thoughts that, oh, I didn't study, I didn't read this paper, and you have a colleague potentially who's not in the same situation, your thoughts are already primed in the morning that you're not prepared or you're not good enough or you're not this or that or the other thing. And that's actually is probably something that women deal with every day and on a day-to-day basis, which works to their disadvantage. Obviously, all of us have made our success in all these fields, and we do it, and we are capable of doing it. And we didn't have to necessarily read that entire paper the night before to get the idea and to make a success of ourselves. But fighting my own thoughts all that time, I really wish I would have discovered coaching a long time ago, because that really provides a lot of strength to me now.
How did coaching change the way you think, and what difference did it make in your life?
Oh gosh, I could talk about that for quite some time, but I will try to keep it short. I mean, you and I worked together for about 6 months last year. And foremost, you showed me from meeting with me every week is that I was repeating some habits and some thoughts that did not serve me. That's point one. It really changed my life. And what you helped me see and what you helped me do was to prioritize my goals and prioritize my daily life. You showed me that I would be able to rewrite the programs in my brain, that the brain is programmable, and that if I prioritized things according to my self-care first, my family, my husband, and so on, that would help me distribute my energy over the week, because the decisions were already made in advance according to my priorities. And you and I identified obstacles that could disrupt this pattern and how I could prepare for those obstacles in order to keep my energy distributed evenly. Before then, I was operating kind of in a sprint mode where I would work really hard to get a paper finished or to get something done, and then I would exhaust myself and kind of have a crash afterwards. And that was not working for me at all. And I would still be in that situation if I hadn't had coaching. So I remember being exhausted and discouraged. And now I have tools to help me be hopeful and energized and prepared. And it really feels fabulous.
That's beautiful. You mentioned that not only you do interventions as a neuroradiologist, but you also work on papers. So you also do research. Can you tell our listeners about that as well?
Absolutely. I don't do basic science research. I do clinical research, which means that I'm using the information gathered from our patients, CT data, MRI data, and so on, in order to generate a hypothesis. And we look back mostly retrospectively to see if we can find information that supports the hypothesis or not. My recent paper was looking at an artificial intelligence program that detects intracranial or bleeding in the brain. And we looked at the program's performance, how well it did, how many times it overcalled bleeding. But mostly what we looked at was when we had the information from the artificial intelligence, which pops up on the screen as a kind of widget, was that able to speed up the patient's treatment and shorten the hospital stay and so on? Because that is really the real benefit of artificial intelligence in medicine, is sort of to bring the critical pathology to the doctor's knowledge immediately. The other type of research that I do, the prospective kind of research, is participating in treating patients, but enrolling patients in advance into randomized clinical trials that have been brought to our center by my boss, by our section head. And then we actively participate in the randomization process and the treatment process. And these kind of prospective trials are usually multi-center, even global, and they collect data in order to show whether one treatment is better than another.
It's very interesting that you mentioned artificial intelligence, this machine learning approaches, and their use in neuroradiology and in general in radiology. I noticed the same in our hospital and in other hospitals. There is new software which utilizes those new methodologies. And of course, I hear different conversations that happen even when we are presenting this type of posters and people are walking around. And one of the things that I hear is that some of those methodologies actually are showing that the machine learning can detect certain pathologies even better than neuroradiologists. And especially if we're taking into consideration a factor of fatigue, decreased attention, that makes sense. And that makes people start talking about machine learning algorithms overruling and overtaking the space of neuroradiologists or radiologists in the future. What is your perspective on this question?
Great question. My perspective is that it is still only an assistive type of device. It had a certain ability to detect hemorrhages better than the doctors, but they were not clinically relevant. They were too small. And on the other hand, it was overcalling hemorrhages when the patients were post-operative, when they had already had craniectomies and so forth. So in the middle ground, as I said, it can be helpful because it will bring the patient to the doctor's attention faster, because it would be, yes, there is a hematoma versus no, there is not a hematoma. But the relevance of the hematoma, the size, the location, the clinical relevance absolutely has to be determined by a physician. And we have enough work to do. This device or software only helps us and makes it easier for us not to miss important things. And it definitely would only be relieving us of some work that we have to do and not taking away any work that we have to do.
That's good to know. And I think also to prospective students who want to become radiologists or neuroradiologists, that they don't need to fear new methodologies, that they will only help.
Correct.
In this podcast, we are emphasizing the international component of being a neuroscientist or working in this field. And you have experience of working both in the United States as a neuroradiologist and now in Europe. What is the biggest difference that you see between these two places of work, and in terms of being a medical doctor and also as a person conducting research?
Yes, the medicine is the same. A lot of it is the same. And I was really happy to see that. I did not enter into a situation that was unfamiliar to me. That was definitely a plus for me. But a major difference, which is nothing bad, but a major difference is that the length of stay of the patients is not a problem in Switzerland. There are pressures in the US to get patients out of the hospital as soon as possible. In fact, when I was visiting my parents in Florida, I saw a sign advertising an outpatient hip replacement. And that is really taking it to the extreme. In Switzerland, there is no such pressure at all. The patients come in the day before the surgery. They stay for days after the surgery. We have a garden in the middle of our two clinics, what we call clinics. There is shade, there is trees, there are waterfalls. And a lot of times when I go to visit my patients after their procedures, they're not in their rooms. They're in the garden. And that kind of relaxed approach to healthcare is amazing. I love it. Even they take patients on their hospital beds outside into the garden. That's one major difference that I really like. Also in Switzerland, there's not a hysteria over paperwork, which when I first came, I found a little strange because in the US, we're very much trained to document excessively, document everything. There's a lot of standards that have to be met for anything from residency programs to doing carotid stenting. There's just a lot of data that has to be collected and proven and accredited, and there just isn't that pressure in Switzerland. And that also leads to a more relaxed atmosphere for everybody working at the hospital.
And from research perspective, what do you see? What differences?
From the research perspective, it's quite the same with everything from needing space on the computers to keep your data safe, and the ethics approval process, and working closely with the residents and even the medical students for them to get papers to complete their academic requirements. That has been very much the same and very enjoyable for me because I like working with the younger doctors.
You talked at the beginning, we talked about stress that comes with being interventional neuroradiologist. Maybe you can recall a case when there was a very stressful situation. However, you with your team managed to overcome the stress and have a very good outcome.
Oh, yes. All of the cases are stressful and some go easier than others. One of the challenging cases I had early on when I came to Switzerland was a man in his 50s who had a fistula behind his eye. So that means that the arteries were flowing directly into the veins in an abnormal way. This was making his eye protrude, and the eye was red and swollen. And he had this for about a year because the neurosurgeons had opted to treat it conservatively. And it is true that sometimes these fistulas will resolve on their own. This is a fact. But the man was developing vision loss and developing problems with the eye in terms of glaucoma. And it was at the point where it needed to be treated. The problem was between the year before I was there and the year when I came there, the access to this fistula behind the eye, which is normally through the veins, the access had closed off. It had thrombosed. So the traditional form of treatment was not available to us. So I had to access the space behind the eye directly through the orbit, not through the eyeball, but next to it. And so I had to put a needle along the floor of the orbit underneath the eyeball and connect up with this abnormal vein and put coils in the vein. And I had never done this before, but I knew that it was a technique that was done. I actually reached out to the editor of our National Society's magazine because he had published a case series of 4 cases. And I talked to him directly, and he told me the nitty-gritty details of how to do it, which was very nice of him to take the time. And I followed exactly what we said, and we treated it successfully. And by the next day, the redness and the swelling and the protuberance of the eye was already improving. The reason it was a challenge is that how do you explain to the patient, I'm sticking a needle behind your eye? and this is how we intend to treat your problem. And I'm always impressed how the patients, they take this information and say, okay, doctor, if you think that's how we're going to fix it, then that's okay with me. I'm really impressed by their bravery. Also, you mentioned the team, and I did have to work with the technologists in order to decide how to disinfect the area, how to position the patient's head. We had to work with anesthesia, that I had room to work and they had room to keep him asleep. I also had to work with the ophthalmologist in case something did go wrong, that they would have to perform emergent surgery. So there was quite a lot of planning for the procedure.
That's very interesting. How often do you face the situations when you need to take absolutely new approaches that you haven't used before?
Oh, all the time. Our field is making tremendous strides. It's absolutely amazing how the practitioners of neurointerventional radiology around the world are working with the vendors who make the catheters and make the materials and make the coatings on the stents and do the bench research in order to bring this to clinical fruition. It has been exploding in the last 10 years. There's always new devices, always new techniques. You have to stay on your feet and stay active and learn these things in order to provide the best treatment for the patient with the least amount of complications.
So not only you're treating patients, not only you're doing research, you are constantly upgrading your knowledge.
Yes.
How much time do you dedicate to learning new things?
Well, the pandemic has been really great in this regard because our webinars and the ability for the online streaming has been absolutely amazing with our annual congresses. Also, for example, there are people from all over the world live streaming lectures, which would never have been possible when it always had to be in person. And so the amount of actual usable and the latest kind of information that's coming through our annual congresses is just unbelievable. You hear from people you would never have had a chance to hear from before if you didn't travel to France or to Toronto or the United States or wherever the big meetings are being held. Even in Switzerland, there's big meetings. And to be able to just log in from the comfort of your couch and learn something amazing from the experts is just tremendous.
If you would list 3 major trends in neuroradiology at the moment, what would those be?
Well, the first one is, as I've alluded to already, is the global cooperation in establishing these prospective trials where we can really determine what is the best treatment by an evidence basis, not just because it worked last time, so we're doing it again, I'll do it again this time. And we have tremendous data that allows us to do our stroke treatments with complete confidence that we're doing the right thing for the patient. And also that the faster we push to get the patient on the table, that is just like a heart attack. The faster you get in and do the treatment, the better the outcome is. And the trend is continuing to expand the indications for stroke outside of the most common types of stroke and moving on to the less common types of stroke. So it's expanding the population that we can treat. Second trend is moving into robotics and to, again, streaming for online teaching, for online assistance in cases. And the robotics involves staying out of the room and using the joystick, using controls outside of the actual angio room to control the catheters, to control the movements of the catheters. And that way, the team and the doctor are less exposed to the radiation actually that's going on in the room. I mean, we always have to wear lead in our caps, in our goggles, around the body, and so on. I mean, that leads to fatigue and is part of what we do. But with the robotic assistance, you are comfortably sitting, like I said, outside of the room and managing everything from a control panel. And then I would say the third biggest trend is definitely the artificial intelligence. And it goes way beyond just saying that there is an intracranial hematoma or not. The artificial intelligence can hopefully be put to use to look at, as I mentioned earlier, how big is the hematoma? Where is the hematoma or the tumor? How big is the tumor? What are the components of the tumor? Does it enhance quickly? Does it shrink after this treatment? The artificial intelligence can take many, many different data points and merge them together and spit out, hopefully, algorithms that help us to interpret the images better and allows the neurosurgeons and the neuro-oncologists to treat the situations better.
Can you list any new treatments that allow to treat people that maybe were not considered even treatable 10 or 20 years ago?
Yes, there are many situations. What has happened recently is not that they weren't treatable before, but now they are treatable so much faster, so much more efficiently, and with less complications. That has been the tremendous change in the last 20 years. From stroke to arterial venous malformations in the brain, we have much better catheters. We have catheters that can detach, leaving a little bit of the catheter and the embolic material in the brain. We have better embolic materials. And by that, I mean a glue-like material that actually goes inside the malformation and decreases the risk of bleeding. I would say it's much more elegant and more refined now.
Probably also less invasive. At least this is what I saw in neurosurgery, that we have less invasive approaches, for example, with laser ablation. Do you see this trend in interventional neuroradiology as well?
Yes, absolutely. Well, what just came to mind
Mhm.
about what you asked about a patient being not treatable in the past is, for example, with aneurysms that are quite large and have distorted the vascular anatomy of the brain, that would have been a very difficult surgery in the past. And now, through these endovascular techniques that we use, the catheters and the coils and the glue and the tiny stents for intracranial use, that allows us to make a construct which treats an aneurysm, a giant aneurysm, for example, that would not have been treatable in the past.
How many centers around the world have this type of technology? How widespread is this? Is it that only few centers around the world have these major trends going, or these technologies are spreading into many places?
The technologies are definitely spreading into many places, but we always have to be careful that the practitioners are well trained and are familiar with the use of the different devices. It is not only in a few centers around the world, it's in a few centers in every country, I would imagine, or at least of developed countries. And the problem lies with the experience of the neurointerventionalist. It's something that is very unique and does require dedicated training. And that's part of our society's initiatives, is to make sure that the practitioners who are certified to do these interventions are certified because they are well trained. We have training requirements and accreditation requirements that will keep this treatment in good hands.
And probably spreading the knowledge about those new methodologies and their use and organizing those trainings is very important. This is something that I see with the physical therapy, because there are many new approaches and use of virtual reality and robotics and brain-computer interfaces. So a lot of technology is being introduced into the field, but the usage of those technologies is still very, very small, although the technology exists, and people are not aware, number one, and then of course they're not trained in it because they're even not aware of that technology. So from what you said, I think it's quite a similar situation still. The technologies are developing faster than we are adopting them. What do you think about that?
Yes, absolutely. And that's why it's been so amazing to be able to dial into our annual meetings and to see experts from across the world talk about these new technologies. I know that our society, the Society for Neurointerventional Surgery in the US, also has close collaboration with patient groups and with the government, and has an educational approach as well to keep patients, hospitals, other doctors informed of what we can offer.
You already mentioned that we both are certified life coaches, and I know that you are helping with your life coaching skills people who want to get into the field of medicine and maybe even to get into the field of radiology or neuroradiology. Can you tell more about that? How you help them, what you do, and what are the outcomes of this?
Absolutely. That is one of my favorite things about what I do, is working with students and residents as a mentor. And I have expanded that now into coaching, and not only in my hospital, but online. I'm building a business with mentoring / coaching for students who have graduated outside of the United States but want to do a residency in the United States. I help them with their interview skills. We do practice interviews, and I discuss their personal statements with them and basic things like that. But I also incorporate coaching, the coaching that I have learned from the life coach school. What that means is that we discuss their priorities, we discuss their goals, and we work backwards from that and look at what are our thoughts surrounding these goals. and these obstacles. And we talk about how thoughts generate feelings about situations, which then lead to certain actions, which can be positive or negative, and then ultimately produce a result that could be positive or negative. So if you start with the result that you want and you work backwards into what actions do I need to take to get there? How do I feel in order to take these actions, and what thoughts would serve me to lead to the actions that leads to the desired result? And I love to share that approach which you taught me, and I share it with other people, and it's just so amazing when they see that they are in charge of their brain and their thoughts, and then subsequently their results.
What difference do you see between when you were just mentoring students and now when you're end mentoring and coaching?
The biggest difference is that you can give all the advice in the world to someone and it somehow falls flat. My experience and what I can share with students is helpful to a certain extent, but I can't tell them what to do. And I can't say, well, because I did this, you should do this, or because I didn't do this, you shouldn't do this. They need to make their own decisions. And the way that they can make the educated decisions is by examining their thoughts about one path or another. And how does that make them feel? It's giving them the ability to work through a problem or a challenge for themselves instead of me just giving them advice. And that is a deeper relationship, and it'll give me a much deeper feeling of satisfaction to know that I help them learn a process that they can take and use on their own.
What would be your advice to people who are getting into the field of neuroradiology? Maybe they're still considering or just starting this path. What would you tell them?
Well, along the lines of mentorship, my advice would be to seek out a mentor and ask questions, ask about other people's experiences. I think actively searching for mentors is something that everyone should do. And it doesn't mean that if you ultimately decide not to do neuroradiology, that this relationship is not going to be helpful to you, that you can find mentors in any field, because the mentorship is a two-way street in the sense that if it starts to build a relationship, if it works and you have open lines of communication, you can share ideas, you can learn from each other, and this person can support you in whatever you decide to do. Medicine has commonalities in all of the fields, and searching out older people's experiences is probably the best advice I could give.
What are your next steps? What are your future plans?
My next steps are to actually introduce the concept of coaching into my department and to my hospital, because it can really be critical for preventing, or even if it's already occurred, treating burnout. And I think there's been a lot more acceptance and recognition that we as physicians need ergonomic help. We need to have a life outside of medicine, and that the amount of work we have to do on a daily basis is too much for someone to come back to every day without tools and a way to organize their time according to keeping themselves healthy first. And I think that my department is receptive to this. I have already sent out some information in this regard, and I have other colleagues who are also interested in it. So I would like to keep up the pressure to encourage doctors to take care of themselves so that we don't have a crisis where people are leaving medicine because it's too much.
Our podcast is called Neurocareers Doing the Impossible. And from what you told us today, you're doing impossible almost every day, and probably several times a day sometimes, when you have all those unexpected situations and maybe approaches that were never used and situations that you never faced. What would be your recommendation or suggestion to those people who are faced with the situations of impossible and who are thinking that it's impossible? What would be the best approaches and ways to make things possible?
I am a big fan of journaling. Okay, I learned it from you, and I have found it so unbelievably helpful in my life. I mean, you asked me just to start 5 minutes in the morning and 5 minutes at night, and now I do it every day. And it's just a way to get your thoughts out of your head onto paper. It's a way to talk to yourself, but the kinesthetic act of actually writing it is so helpful. I would have never believed it until I tried it. It feels like a support for me. I look forward to it. I need it. I need to journal. And like I said, I just write down what my thoughts were in a certain situation, and it takes away that kind of spinning thought. It takes it out of your head and onto the paper, and then you can move on. So that would be a suggestion, that people do incorporate journaling into their daily practice.
And also, probably you can see the situation and the possible solutions more clearly when you write things down. Did you notice anything like that?
Yes, absolutely. Because as I said, you kind of put that troublesome little thought that's running around your brain, you get it down on paper, and then you say, okay, that isn't helping me to continue to think this. What are some other options? You have the paper in front of you, you have the pen in your hand, and you just start exploring what else could have been done in this situation, or what you might do tomorrow, or how you might approach something differently. And your brain will come up with the ideas, and your brain comes up with the solution. It's also probably taking these 10 minutes to be with yourself. That allows your brain to free up and come up with ideas, because you're saying, these are my 10 minutes for myself. If you don't journal, then you don't really actively take that time for yourself.
One question that I didn't ask and I wanted to ask, how do you see the field of neuroradiology 20 years from now, or maybe if you want 50 years from now? You pick the timeline.
Yeah. Well, I think, as I mentioned earlier, this robotic approach to intervention is going to become more mainstream, and mobile treatments will probably become more mainstream. It was kind of laughed at in the beginning, the first mobile CT scanner for treating stroke. I mean, it was laughed at because it was a silly kind of pipe dream, but it's real now. And you can go to the patient's house, put the patient in the squad car, do a CT scan. You can live stream the patient's examination by the paramedic to a neurologist at the hospital, and he can confirm how high the stroke score is. He can look at the CT, and he can decide to give thrombolysis from the hospital, and the paramedics are in the field. And I think mobile treatment in 20 years or 30 years will expand to actually doing catheter-based treatment in the field. Another thing that I've always been interested in is in nanotechnology. I like to read about what they're doing. It's kind of in the background, but with mice and with bench work. But I think this is really fascinating that they can put cancer treatments. They can even put radiation cancer treatments into nanoscintillators and put that directly into a tumor. Of course, as I said, in mice at the moment, but in 20, 30 years, I'm sure we can deliver these nanotubes and nanoscintillators through our catheters directly into the arterial blood flow to a tumor. I find that very cool.
If anybody is interested to learn more about the work you do, and maybe reach out to you and ask about mentorship or about the coaching approaches that you are integrating into the life of medical doctors and students, where can they find this information?
Well, how to contact me is my first name dot my last name at gmail.com. So it's Kristine.Blackham@gmail.com. My website is currently under construction, and that's kblackhammd.com. Also, as I said, I'm at the University Hospital of Basel in Basel, Switzerland, and I'm contactable that way.
Thank you very much. And maybe you can suggest some reading to those who are still contemplating. Should they go to neuroradiology or should they go to neurosurgery? Actually, I had students who worked with me on research projects and they wanted to be neurosurgeons. I have a couple of those actually. And after watching the work of neurosurgeons, they said, no, we're going to neuroradiology. So those people who are still deciding, maybe there are some readings that you can recommend.
Well, one thing I wanted to mention was that in our fields, we have a great deal of collaboration between neurologists, neurosurgeons, neuroradiologists, and it is wonderful to be part of a collaborative effort to improve patient care, especially in academic centers. Everybody learns from everybody else, and there is a real collaborative approach rather than a competitive approach. And actually, to do neurointervention, you can come from a background of radiology, but you can also come from a background of neurology or neurosurgery. If you do those residencies in the United States anyway, there still is a possibility to do the endovascular techniques. But the place to read about that would be at the Society for Neurointerventional Surgery.org. So that's SNIS.org.
And we will add all this information and your contact information and information about reading certain things. We will add all of that in our podcast notes. Maybe there is anything that you want to say to our listeners before we end our today's podcast?
That if you're working with Dr. K, then you are in good hands.
I want to say, our listeners, I didn't ask for that, but
no, I am a big fan. I am a big fan of Dr. K.
Oh, I appreciate your kind words. I even don't feel a little uncomfortable, but yeah, I appreciate it. Thank you very much, Kristine. Thank you.
You're welcome.
Thank you so much for coming to our podcast. I'm sure our listeners will enjoy this podcast and all the information you provided. And I hope to see you in our podcast a year from now to see what happened and with your program and with your research and with the newest developments. I would love that. So that's my wish for the future. Thank you. Thank you very much, Kristine.
That sounds great. Thank you too.